Hello, everyone. I'm Dr. Darsha,
And I'm Dr. Altamash Raja,
and welcome to Medicine Redefined.
a podcast where we will explore the often overlooked but necessary components of health, what we consider to be the fundamentals.
We will investigate topics and practices that can give you and your patients the best chance to optimize a healthy lifestyle. It's time to move the needle forward and put the health back in healthcare. All right, what is going on, everyone? Welcome to this week's episode, where this is our second part with Dr. Nicole Harkin doing a deep dive into cardiovascular disease. Now, if you haven't listened to part one, I highly encourage you do so, which was last week's episode 55, where we delve into the basics of cardiovascular disease. We discuss risk factors, cholesterol, statins, and so much more. In this week's episode, we are going to be discussing lifestyle interventions. So we first start off with understanding what preventive cardiology truly is and what Dr. Harkin's approach is with her patients. We then break down the lifestyle interventions into their different components. So we touch on the benefits of being plant-based, or essentially incorporating more plants into your diet. We also talk about supplementation, exercise, and of course, as you know, we love to talk about sleep. Yes, we even talk about how sleep can affect cardiovascular health. Now, I don't want to delay you any farther, so let's get on this journey and let's get further into this deep dive into our hearts. All right. Hello, everyone. Welcome back to another episode of Medicine Redefined. This one is a part two with Dr. Nicole Harkin. So I'm going to say this right off the bat. If you haven't listened to part one, highly recommend listening to that first, getting the fundamentals down in regards to cardiovascular disease, lipidology. And then this episode, we're going to be touching on kind of high level interventions, right? Especially from a lifestyle focus, nutrition, sleep, etc. So welcome back, Dr. Harkin.
Thank you guys so much for having me on again. I'm excited to be here for part two.
Yeah, absolutely. As we are. So let's get right into it. We want to focus this talk mainly on your approach to patients and kind of, when a new patient comes in, when you're looking at it not only from a pharmacological perspective, but also an intervention perspective that, we obviously know exercise, sleep, all these things matter. Take us through, I guess, just general overview for now. When a new patient comes into your office, what's your approach?
Yeah, so it really depends on the patient. I have a very tailored and personalized approach depending on who the patient is. Is this primary prevention? Is it secondary prevention? What are their risk factors? What testing have they already had done? What further information do we need to really determine sort of their overall cardiovascular risk and then figure out how to optimize it? Are they eating a standard American diet right now? Are they whole food, plant-based, no salt, no oil, no sugar? Where are they on that spectrum? And so every patient obviously is different. And I think that's really important, and what sets preventive cardiology clinic approach apart from sort of other kind of standard visits, which just aren't as well equipped to really go in depth and analyze these approaches. And so we know from data that the average patient seeing the average cardiologist gets no more than 3 minutes of lifestyle modification advice. And typically that ends up being eat healthier, right? And we know that doesn't work. And so really looking at a patient from as an individual, figure out what are their goals, what are their barriers to change, and where do we need to go from there. So in terms of a high level approach, I typically have my patients fill out a pretty in-depth intake form prior to seeing me. I also like them to upload any prior testing, both diagnostic as well as laboratory, in advance of the appointment, so that we can really hit the ground running. And I also include on that form, what are your goals? Like, what do you identify as your major risk factors, and what are you hoping to achieve? And then just as, typical going through a typical visit in terms of their personal history, their family history, their medications, their supplements, all the things that we're used to sort of really getting into. But then I also do a pretty in depth lifestyle intake. So I do ask them a lot about nutrition, not only what's a standard sort of breakfast, lunch, dinner, snack situation for them, but also how often are they consuming red meat, unprocessed red meat, packaged foods, things like that, to get a really good understanding of sort of where they're at. I also ask about sleep, both quantity and quality. I ask about stress levels, sort of rating them on a scale, and all of, and then exercise obviously as well, what they're currently doing. And then we go through together the current tests that they have done, and then decide sort of what other further testing might help us fine tune what their risk is. And I think we talked about this in part one, some of the typical tests that I typically look for and order, again, depending on the patient and where that's appropriate. And then we circle back and we look at everything together and then really figure out what is their biggest risk factor that we need to really work on and modify, and what's our approach going to be. As in line with our guidelines, more often than not, it is a lifestyle first approach. So how can we make changes, make tweaks to your diet, your exercise program, what have you, to achieve our goals? And then we reevaluate. And then if pharmacologic therapy proves itself to be necessary, then we talk about that at that point.
Yeah, I mean, the word that comes to mind is comprehensive, right? I mean, you talked about just even prior to seeing the patient and how much data that you're looking at, and we spend a lot of time, as you mentioned, talking about diagnostics, particularly lab markers. But I really love the fact that you talked about, hey, like, what are your goals? What are you hoping to get out of this? I think that's so important to highlight right at the beginning, and then I think this concept of therapeutic alliance that Dan Pope came a long time ago talked about, although he was referring to it from musculoskeletal rehab standpoint, but I think that applies here as well. I think that if you can identify the patient's goals, you're much more likely to have that relationship therapeutic alliance. So I really appreciate that. Thank you. I think that when we're focusing on lifestyle medicine, right? Some of the things that we've talked about offline is when we look at it, depending on who you're talking to, the pillars are sleep, exercise, distress tolerance or stress tolerance. You're looking at nutrition, right? Am I missing anything else, or is there any other bucket that you look at it from that
Those are
perspective?
the
Or
big ones. Lifestyle medicine also specifically delineates substances such as alcohol
right,
and tobacco separately, as well. And then community support, love, that sort of
awesome.
thing as well, would be kind of the last pillar.
So I have a framework in my mind of how like I like to approach it when I'm looking at it from cardiovascular health. But wherever you want to start, which one do you think out of those is kind of the bedrock, if there is even one, or wherever you'd like to start, we can go down that pathway first.
Ooh, the bedrock, I like that. I would have to say that in terms of, levers that we can pull that truly impact in oftentimes dramatic ways, nutrition is really king, I think, in terms of how can we make major changes that can either lower our blood pressure or lower our cholesterol or all of the above.
Awesome. So let's start there. And it's
Why
interesting that
not?
you picked that one. I mean, right off the bat, we're going to pick the most polarizing topic. I love it. All right, this is going to be the biggest one to tackle, but I appreciate that. I think that, you know, again, I get it, the sense every single time we have the conversation that again, it's talking to the patient and really assessing where they are, what kind of diet you just mentioned. Right? Are you taking a lot of meat? What's your current diet like, and then we can help you get to your goal. So this is a highly contested, highly debated topic, right? Different, is red meat, as you mentioned, is that bad for you? Red meat and cancer, you hear about that. And then, every single study comes out, whether or not it's a good study is a different discussion, but it's all over the media and people in different camps, low carb, low fat, high fat, keto, fasting, all the kind of stuff. They'll take that study and they'll say, well, this is what's really, really good for you. The way that I always think about it is, well, it depends which lens you're looking at it from, right? For instance, let's just take um, the discussion of, okay, well, so in my world of fitness and sports medicine, and where I'm treating a lot of athletes, right? Let's if you're taking a physique competitor and they need to hit a goal of protein intake, right? So can you be an all plant or a vegan diet and be a high level physique competitor? Sure, you can. But we have to appreciate that it's going to have some challenges, right? Can you, should you, right? And so, for our lens, from a cardiovascular perspective, what is your overall philosophy when you're looking at nutrition, when you're having that conversation? I know it varies individual to individual, but do you have one?
Yeah, I think that from an abundance of data, both randomized controlled trials, epidemiologic data, short contained feeding trials, and as is reflective of the ACC/AHA guidelines, we know that ideally our diet should be composed of as much vegetables, fruits, whole grains, legumes, nuts, and seeds as possible. And where, how, in what context, and with what other things, those are sort of the margins at which we debate about those things. But I think that, and it's interesting you mentioned from the offset that this is the area where we see the most is the most highly contentious. And it's interesting because it is and it isn't, right? Like if you listen to the media and these different fringe camps about diet, I think it does end up getting really confusing really quick for the average person. But I think if you bring together sort of nutritional experts across the globe, there's actually a lot more commonality when it comes to these diets than you would otherwise think. So sure, maybe they argue over, the relative component of starchy versus non-starchy vegetables, but I don't think anyone is saying that vegetables in general are bad. I think most nutritional camps would agree that that processed and packaged foods and sugar is not good for you. So I think there actually is, if you actually line up sort of a healthful plant-based diet, a healthful Mediterranean diet, a healthful low-carb diet, you actually see a lot of commonalities. And then, sure, we can definitely talk about sort of the differences afterwards. But when you look at from a healthful cardiovascular perspective, I think the ACC/AHA guidelines did a pretty good job of sort of delineating what is known, what is not known, and what should we really emphasize. And again, then it gets back to sort of what are the patient's goals, where are they at right now, and where do they want to go. But in general, moving patients towards eating more whole unprocessed foods is definitely supported by the data.
So, Dr. Harkin, one of the touted diets out there that has been at least shown, I put quotes on this, to reverse heart disease is the Dean Ornish diet, right? Which I believe he created in the 70s. And I think I'm getting this right. The Dean Ornish diet is, at least it's low fat, I think is like the main thing. And then it's whole food plant based. But to me, I find it interesting, at least, that created in the 70s, that's around the time where we thought fat was terrible for you. And, we've since changed our minds since then. But one, what are your thoughts on that diet, right? I think that word reverse there is pretty key. We talk about reversing or stabilizing heart disease. So what if patients come up to you and they ask you about this diet, or they've tried this before, what's your take, at least, on the Ornish diet?
Yeah, so the Ornish diet is, as you said, it's actually a vegetarian diet, so it does
Okay.
allow low fat dairy in it, and it was created by Dean Ornish, as you said, and it was also importantly part of a comprehensive lifestyle program. So in his studies, it did incorporate moderate exercise, stress
Yeah.
management, social support, and all of these other things. And, importantly, they were pretty small trials, but they were randomized and they did show improvements in, as I recall, exercise tolerance and reduction in angina, reduction in needs of medications, and things like that. So I think, as with any sort of smaller trials, they're very provocative and hypothesis generating. But I think in terms of disease reversal, we have to be very cautious with how we say that.
Right.
And I think when patients ask me about that, my response is, most modern cardiology trials, what we're looking at is not, most of them are not repeating angiograms and looking at plaque burden, right? That is not a typical endpoint for a cardiology trial. Most cardiology trials, we're looking at MACE, right? So we want heart
Mhm.
outcomes, revascularization, heart attack, cardiac death, big heart outcomes. And ultimately, that's what matters to patients, right? They don't care if their plaque went from 30% to 20%. Now, if their angina went away, that's really important,
Mhm.
right? If they don't have a heart attack, that's really important. So I think that we have to be careful in terms of, does plaque go away? Maybe, but in general, that's not likely the largest. Maybe partially that's happening. And take statins, for instance. Statins do likely reduce plaque in studies. We now know that there's definitely plaque burden that gets reduced, but that's very unlikely to be the major mechanism, at least at first, by which they're reducing cardiovascular endpoints, right? We know
Mhm.
that statins early on, as soon as someone has an MI, you give that and they have better outcomes in 30 days. That's not plaque regression, right?
Right.
That's endothelial dysfunction changing, that's inflammation, that's all the other things that happen. So I think it's a really interesting conversation, but I think that ultimately it's not really what matters. And so I think I prefer with patients to really focus more on, how can we make you feel better and live longer? If your plaque goes down by 10%, great.
I like it. Yeah, that's a good point.
Awesome. So, you mentioned that there isn't anybody who would say that plants are bad for you. I would argue there are some very
There's the
uh,
carnivore crowd. That's true.
right. And and they would argue that some of the the toxicity in plants and whatnot. And I don't think that we're going to visit that aspect of this conversation. But if I'm not mistaken, are you plant predominant, or are you vegetarian only at this point, or for your personal diet?
I'm plant-based. So
Okay,
I was vegetarian. I became vegetarian a little over a decade ago now,
okay,
and then plant-based within the last couple of years.
gotcha. So for those who don't know the differences, what does plant based versus vegetarian mean?
Yeah, so plant-based has variable definitions, but for the most part, it's defined as either plant exclusive or plant predominant, and specifically distinguishing from, say, vegan or vegetarian diets, is defined not only by limiting or completely eliminating animal products, but specifically focuses on consuming whole food products. So, as much as possible, whole foods in their whole form without being as processed. And so, so the foods can be, minimally processed bread, for instance, or even, something like tofu, but ideally not processed. So this distinguishing it from, say, a vegan diet, which can and often may include highly processed foods like French fries and Oreos,
Mhm.
that would not be inclusive of a whole food plant-based diet.
Awesome. So, and to your earlier point, I would point the listeners to John Berardi's podcast. I think one of the very first series that came out, I think was called Diet Debate. Very interesting, where it's a three-part series, and they're looking at, to your point, his podcast was all about finding the common ground between different points of view, and
Hmm.
it's actually quite interesting that when you really sift out the people who have the loudest not platform, but just the message on either ends of the spectrum, most people kind of fall in that camp. And so I think that was pretty interesting. But you talked about a little bit about the mechanism statins, right? Or you touched on briefly. And I think no discussion can be complete, science-based discussion, without talking about mechanisms. So I think the standard American diet, which is heavy on meat consumption and processed foods and whatnot, and very little on plants. And most folks agree who are in that middle ground that we need to increase our plant intake, as you've already said. Mechanistically, what's so good that is beneficial for our heart health?
Yeah, so plants are, and when we say plants, again, we're talking about vegetables, fruits,
Mhm.
whole grains, legumes, nuts, seeds, potentially plant oils as well. So in general, we know that that plants are high in things like fiber, things like potassium and magnesium, polyphenols, typically in the heart healthy fats such as poly and monounsaturated fat. And they tend to be very low in cholesterol and saturated fat and sodium and things like that. And so we can go through sort of different mechanisms by which all of these things are helpful to our bodies. But essentially, we know from sort of long-term epidemiologic, both prospective and retrospective studies, looking at large populations, and whether you're taking omnivorous populations and looking at, say, Haynes data, or if you look at specifically sort of plant-based communities like the Adventists, Epic Oxford, things like that. Regardless of sort of where you fall on the spectrum, in general, we see that the more plants you consume, the lower the risk of heart disease. Now, obviously, there's lots of limitations to epidemiologic data, but it's patterns that we're looking for, right? And when you see it time and time again, you see it in people who eat exclusively plants or who eat some plants. I think that it becomes very helpful, and it definitely can inform us. So that's sort of a lot of the big data that we have in terms of heart health outcomes. And then we can also break it down into sort of the risk factors, right? And that's where we get more of the randomized controlled trials and the feeding trials and things like that. And so we know that eating plant-based diets, like for instance, say the portfolio diet, that's a specific plant-based diet that's very helpful. And we do have randomized controlled data that shows that it can lower LDL cholesterol significantly. And so we can look at different plant-based diets in terms of how they can lower cholesterol, blood pressure, body weight, inflammation, and all these other risk factors. And so taken together, that's sort of how we understand how the impact that plant-based diets can have on our heart health.
Yeah, I find the various mechanisms to be quite interesting, and it obviously would be several hours here if we try to explore every single one of them. But a study that I read actually recently, or just kind of screened the abstract when I was, thinking about our discussion later today, was the at least the lens of looking at the gut microbiome. And we had Dr. Will Bolsowitz come on, and we had a two-part series with him talking about all the different aspects of how the short-chain fatty acids and feeding our gut microbiota can really help augment cardiovascular disease and a bunch of these markers that we've touched on in the first episode. So I think that's also something that's cool. Still relatively new. I think mainstream. I think the gastroenterologist will tell you that they've been having these conversations for a long time. Darsh is fascinated with GI system, so I'm sure that he's well familiar with this. Now, the other thing, talking about the SAD diet, right? Most of us are practicing in America as we're recording this in March, and here, on, or at least when the patients come to you, right? And they'll say, well, what, Dr. Harkin, that all sounds dandy, but 4th of July comes around and I need my hot dog and I like the hamburger and I like all that kind of stuff. And just like plants can be challenging, I mean, meat, it's delicious and they're not ready to give that up. Obviously, you strike me as a person who doesn't get the patient to, just completely switch, and you're working with the patient, as you mentioned several times. How do you work with them with that, right? Where we're not going to completely abandon meat because it's not end all be all, but um, let's make it safer. Let's make it better.
Yeah, absolutely. So exactly as you said, I think it's all about really meeting the patient where they're at and figuring out what's the low hanging fruit and where can we make important but impactful changes that feel doable to the patient, right? And it has to be sustainable. So if a patient comes to you and says, I cherish my hamburger once a week and there's no way I'm giving that up, then they're in that pre-contemplative stage, right? They're not making that change. And so let's talk about other things, or how can we mix it up maybe and see if they're open to that. So I think it's all about creating those, and I think we talked about the SMART goals last time, but really, specific, measurable, achievable, and time-based changes that are specific to the patient and what they want to do. And so I think goal number one is creating those goals together, because if they have sort of input into what changes they're making first, they are more likely to adhere to those. And then figuring out where to go from there. So oftentimes I try to focus on what can we add into the diet, first and foremost. So if they're not eating hardly any fruits and vegetables, we go through, okay, how can we get some more in, right? So maybe it's the snack, or maybe it's the lunch, or how can we tweak things so that we can get them in? And what are the barriers currently? Is that you don't like them, or you think you don't like them? Let's explore which ones you do like. Or maybe they just aren't used to cooking them. And so maybe they want to subscribe to any of these millions of services now that you can get healthy food delivered to you. So brainstorming ways where they can kind of figure out how to make some of these easier changes can be really helpful.
Yeah, the subtraction by addition method is something that I've come to be a fan of. Particularly, big shout out to EC Sinkowski, a previous guest, and she talks about her 800-gram challenge. Right, when you're eating 800 grams of plants and vegetables and fruits and whatnot, just because of the volume, you don't have room left for a lot of the other quote unquote crap. And so I'm a fan of that now, especially. Um, no conversation on nutrition is complete without talking about supplementation, of course, right? I mean, that's where people want to start with, unfortunately, and it's not the base of the pyramid. And I hear about this on a daily basis. I think Darsh does as well, and I'm sure you do. So, in that realm, again, I want to highlight supplements are supplemental, hence the name. But understanding that, are there some that have merit when it comes to cardiovascular health, and from your perspective?
So at this point, there's not that many supplements that really do have much benefit, unfortunately. And from a cardiovascular perspective, most of the supplements that we have been enthusiastic about in the cardiovascular community have not typically panned out when they've been studied in randomized controlled trials. Antioxidants have been studied, vitamin C, vitamin E. I mean, you name it, it hasn't particularly panned out. So there are not that many supplements that I routinely recommend for my patients. I do tend to discuss in exclusive plant eaters, vitamin B12 is important to supplement. And so I do have my patients supplement with that. The omegas are going to be a somewhat controversial topic as well, and that could be an entire podcast on itself. But a meta-analysis that Cochrane did and others have done, really isn't showing a major benefit of omega-3 supplementation for the average individual for cardiovascular risk reduction. Obviously, the population that has shown benefit is high dose 4 grams of EPA in individuals with cardiovascular disease who have triglycerides above 150 milligrams. And so that's sort of the one population in which we have seen benefit in an RCT. And so that's sort of the one population. I do think there is some debate within the plant-based community whether or not individuals who are exclusive plant-based may benefit from supplementation with omega-3s simply because they aren't consuming fish. We just don't have a trial that supports that, really. So that's an area, a big gray area. So I think it's not wrong to supplement in that case as well. And sometimes, we'll look, and because you can't get, so you can in plants quickly, you can get omega-3s, but they're the short chain. So algae oil actually is a way that you can supplement and get the long chain. And so many are doing that as well. But again, it's definitely a gray area there. Vitamin D is another one that both omnivores and plant-based individuals are often deficient in. And as I'm sure most of your listeners know, that's a sun exposure. When we get through sun exposure, and most of us are wearing sunscreen or inside, so many of us are deficient. So that is another one, like 1,000 IU a day that I have most of my patients take. But in terms of taking something to actually lower cardiovascular risk, we really, there isn't a lot out there that is helpful. I think that fiber is one where I do look at that closely with my patients, particularly if we're trying to lower cholesterol. If they're not able to hit sort of their soluble fiber targets, we will add sometimes like a psyllium husk or something like that to help get that lower, simply for LDL cholesterol lowering effects. And plant stanol sterols are another supplement that I will sometimes use with my patients, again, for LDL lowering effects.
I love it. Dr. Harkin, I think you have a crystal ball in front of you because you're answering everything we're like about to ask. And we're like, oh, there it is. There it is. She's got it. So awesome. No, that was a perfect review. I was gonna say, as far as omega-3s, yeah, that's what I do. I do an algae oil. Because like you said, I do the chia seeds, I do the flax seeds, but with that ALA conversion, and I actually tested my omega-3, like doing a quant test last year, and I was actually on the lower end. So I actually got to retest. It's been a year now. But quickly, do you ever test omega-3 or like omega-6s with your patient population, or do you not really think that ratio matters too much when trying to make change?
Great question. And I think this is another area where there is some controversy. Certainly, the I think, as with many things in nutrition, it's much more complicated than anyone understands right now. Is the answer. And I don't think anyone truly knows. I do check. I think the omega check is interesting. Again, I don't think that it is the end all be all, but I will take a peek at omega-3 levels, as you said, and that's one of the areas, understanding that it is total gray area, where if it is low, I will potentially, discuss that with omega-3 supplementation with my patients. And then the omega-6 to 3 ratio was very popular for a while. We have too much omega-6 in our diet from all our processed and packaged foods. It's pro-inflammatory. We need to eat more omega-3s. I think it's a balance, right? Just like anything, we do need both omega-6s and omega-3s. And I think omega-6s have definitely gotten unfairly villainized over the last decade or so. I don't know that we know definitively the answer to that, but undoubtedly, it is important to lower our consumption of processed and packaged foods as much as possible. I don't think anyone knows the exact perfect ratio. Most
Gotcha.
people say around 10 to 1 is less than 10 to 1 is ideal. I don't know that we know that
Mhm.
exact answer.
Okay. I want to ask you real quick before we jump into like another pillar here, is another supplement that a lot of people like to take with the dinner time around the world, which is red wine, right? Which has been known with resveratrol, touted as an anti-aging supplement. And I know you recently wrote a blog post or an article on this. So if you can just tell us what's the scoop with red wine? Is it healthy? Is it not?
Yeah, so red wine, as much as everyone would love that it was super healthy, it's definitely again a good, an interesting area of controversy. So. There was a period of time where red wine became very popular from a cardiovascular risk reduction standpoint, when something called the French paradox was recognized, which was that the French seem to have lower rates of cardiovascular disease than would be expected given their high intake of saturated fat from butter and such. And so it was postulated that potentially their consumption of red wine may be contributing to that. And one of the active compounds, as you mentioned, resveratrol, was thought to be potentially responsible for that. We've since studied it more and realized that the amount of resveratrol that we consume when we're having a glass of red wine is very unlikely to be an active enough amount
Right.
to really be having the effect. And there was also certainly some data gathering issues with the French paradox observation in terms of an inaccurate representation of the amount of cardiovascular events that were occurring in the population. So what we do see from large epidemiologic data is that there does appear to be sort of a J-shaped relationship with alcohol, in the sense that obviously those who consume large quantities of alcohol have a higher risk of mortality, but it seems that the lowest point of mortality vis-a-vis alcohol consumption is sort of at that moderate level, which is defined in the literature as 1 glass of alcohol a night for women and 2 for men. In terms of other, it's definitely, there's confounding variables there, certainly. And so we have to be very cautious how we interpret that data. And so, in general, most of us don't recommend that people consume alcohol for its cardiovascular benefits, but that if they do consume alcohol, they consume it in sort of that moderate fashion, as I described. Definitely, what we know is very clear from the data that binge drinking, which is, having more than that, particularly kind of on the weekends, how many of us consume it, is detrimental to our health, and can lead. It definitely is associated with the worst endpoints, both cardiovascular, AFib, MIs, things like that, but also other things like liver disease and such.
Awesome. So we're taking a top-down approach here, and we've addressed nutrition. Well, we haven't completely addressed it, but that's the best we're going to do today. And I'm going to give you the choice. I'd like to either go towards sleep and cardiovascular health or exercise. Which one would you like? Dealer's choice.
Dealer's choice. All right, let's go with sleep. Why not?
Awesome. All right. So sleep it. We all love it. We get none of it. Everybody, the three of us, and of course, medical training. You've got a couple of children. I've got one, and feels like a couple because I'm a first time parent. But we were talking about this offline, and I think now the conversation on sleep and the loss of sleep has, being an epidemic, the volume on it's higher and higher. We've talked about this with a few different guests, and when you're looking at it, particularly from cardiovascular disease, both of us read this book, Why We Sleep by Matthew Walker, very, very good book. But, there were some stats in there that were talked about, now reported to be controversial, but the role of coronary artery disease, the role of heart attacks. I remember him talking about daylight savings time and how when we spring forward, the incidence of heart attacks increases in the neighborhood of 25%. And whether or not that's attributed to the hour of sleep loss, I mean, that's up for debate. But also when you're falling back, the incidence of heart attacks on that Tuesday following the Sunday is down 21%. And that really got me thinking about this. Okay, well, what is the effect? And I'm curious to get your take and from cardiology perspective and your studying of the literature is with the correlation of MIs and sleep loss or sleep deprivation. Where do you stand on that?
Yeah, so I think that the literature is fairly clear that insufficient sleep duration, which is typically defined as less than 7 hours a night, and then also conversely, too much sleep, long sleep duration, which is usually defined as over 9 hours. Is associated with increased mortality, specifically cardiovascular mortality. And we've again, similar to most of our lifestyle pillars, a lot of what we have is epidemiologic data like that, and then biomarkers. And so the different biomarkers that we've looked at, we've seen associations with insufficient sleep duration or poor sleep, with things like inflammation, higher levels of insulin, all these different biomarkers. I think the one that's best studied and is most provocative is blood pressure. So blood pressure has binaural variations, and it fluctuates over the day, and then is supposed to dip at nighttime. So when we're interpreting ambulatory blood pressure, this is actually, I think, one of the most useful reasons to do an ambulatory blood pressure monitor, is because you can actually look and see what someone's blood pressure does at night. And it is supposed to dip. And if they don't, and it's variably defined, but it's usually if their blood pressure does not go down, meaning dip, at least 15 to 20% overnight, then they're considered a non-dipper. And that non-dipping status is associated with increased risk of cardiovascular disease, even above and beyond just the diagnosis of daytime chronic hypertension. And so and that link between poor sleep quality and insufficient sleep duration is most closely associated with this non-dipping status. We also see it in individuals with obstructive sleep apnea and other sleep disorders. And so I think hypertension is certainly probably important in terms of it's how it increases our risk of cardiovascular disease when we're not sleeping enough or when we're not getting good enough sleep.
Yeah, so that indirect mechanism seems to make a lot of sense. I'm curious, what is your explanation, if you have one, about the prolonged sleep, greater than 9 hours or greater than 10 hours for increased mortality? Have you given some thought to that? Like,
I mean, I think it's likely just a marker of something else. So you
mm,
have some sort of chronic disease state, something that is making you sleep longer.
right. And I think that, again, I'm again paraphrasing Dr. Walker when he talked about, his explanation was that most of those folks maybe are dealing with some type of cancer or some type of chronic disease, as you
Exactly.
just mentioned. And the fact of the matter is that the body or the sleep wasn't able to quote unquote save them. And so I think, yeah, that's, as you mentioned a couple of times now with these observational studies and epidemiological data, it's very, very challenging. But sometimes the science is imperfect and it's the best that we have. An interesting paper that I read this morning, and this was published in PLOS Biology. Again, the senior author is Matthew Walker, but Peter T is on it too, Darsh, for you. I'll send it to you guys if you're interested. And they looked at the one of the proposed mechanism of atherosclerosis. It was interesting because they took some of the MESA folks, and the objective markers they were looking at was 7 days of actigraphy, and they were really looking at sleep fragmentation
Mm.
or one night of PSG data. And they documented the white blood cell count, so particularly neutrophils and monocytes, and they correlated that with CAC scores. What they found, both, well, on both instances between actigraphy and PSG data, that the neutrophil count after a night of sleep deprivation would increase. One night for PSG, but also actigraphy. Oh my God, actigraphy over 7 days. Um, I don't understand plaque formation as well as you do, and you explained a little bit. But is that something that is plausible to you in terms of how that could cause premature heart disease or CAD in particular?
So maybe just being reflective of overall inflammation, perhaps. I'm not sure, but that's definitely interesting.
Yeah. Are there any other proposed mechanism? You talked about hypertension, right? With the confounding stuff like age, sleep apnea, that kind of stuff like that. But in terms of looking at atherosclerosis, what is your understanding of, or our understanding of, how that happens?
To my knowledge, that isn't known. I think that, as with most of sort of these lifestyle mediated issues, it's still not fully understood. I think that we have definitely demonstrated that insufficient sleep quality and quantity is associated with many of these different biomarkers, which then increases risk for cardiovascular disease. I think also similarly to something like stress, when you're super stressed or super tired, you don't make great choices, right? So then there's the indirect issues that play as well, where we don't exercise because we didn't sleep enough, or we eat, comfort foods or what have you. So I think it's likely very multifactorial, and there's both direct and indirect consequences at play.
Yeah, I'll disclose last night, about making poor choices. I think it was at 11 o'clock after multiple nights of sleep deprivation. I had these peanut butter dark chocolate bars, and I had just four of them at 11 o'clock without even thinking about it. And this is a point of debate again in this household of why we should even have these, but I digress. Um, let's
You're
switch to
making me
exercise.
hungry,
Okay. My
man.
favorite one was that
I'm fasting right now. You're making me hungry. We can't have food talk.
Darsh is on 24 hour. Um,
24-hour call.
let's switch to exercise. Now, this is definitely my favorite one. It's the one that comes easiest to me to do, and it's just a part of my core identity, I think. And when I look at it, of course, to make it simple for folks, right? We're talking either aerobic or quote unquote cardiovascular exercise, right? When most people look at it, or a lot of strength training, resistance training, right? And I think those are the big general buckets. Before I ask you about that, I'm curious, what does your exercise regimen look like?
Good question. So I typically am so it's definitely morphed over the years, and I will say that some of that is reflective of uh, kind of having a better understanding of the need to have both quote unquote cardio and resistance training. I think I definitely was really into running and a lot of cardio and pretty much exclusively doing that. Right now, my balance is a little bit better, although not as consistent, which is interesting. So I typically, for cardio, a couple times a week, I am on the Peloton. And then we actually recently got a tonal. And so I have been doing more strength training. So I'm trying to do at least two to three of those during the week as well. So I have found that to be really helpful for me for someone who earlier in my life did not do much weight training at all. It's pretty plug and play and makes it pretty easy.
So why the weight training, at least, for the general public? I think many people can understand, obviously, why we do the running, aerobic training, get the heart pumping, but not many do the weightlifting. What's the proposed mechanism behind that being beneficial for heart disease?
Yeah, so I think that is also a very good question and not
Mm.
100% fully understood. So, briefly for your listeners, as I'm sure most of them know, for cardiovascular disease prevention, the ACC/AHA guidelines really do focus on the aerobic activity. We're really trying to get 150 minutes of moderate intensity exercise a week or 75 minutes of vigorous aerobic activity. And as you said, it's kind of easier to understand kind of the hemodynamic changes and all these things that like why that is good for us. Interestingly, the ACC/AHA doesn't specifically recommend within the guidelines to do strength training. I think their language is that should be encouraged. But unlike a lot of other, I think most of the other guidelines, I think for diabetes and for sports medicine, I think most of the other guidelines do specifically call out kind of resistance training. And that's, I think, reflective of the fact that the level of evidence we have for strength training in terms of cardiovascular prevention is not as strong. That said, I think it's definitely emerging and it's definitely very provocative, so I've started to really emphasize that with my patients as well, because I think most of them are getting that aerobic activity that they should be getting, and not focusing enough on the strength training. And so I think the areas in which the data is the strongest is we do have some epi data to show that individuals who do some strength training have lower risk of heart disease, but I think the data is the strongest with specific cardiovascular risk factors. So body composition being one of them. So definitely in terms of reducing visceral fat. I think the other one where we have a decent amount of data is for hypertension management, actually. So there's a handful of randomized controlled trials that show that resistance training definitely can reduce blood pressure above and beyond just what can be achieved with aerobic training alone. And then also in terms of glucose regulation and insulin resistance, we also see that its resistance training is actually better than traditional aerobic activity, and actually kind of can combine with aerobic activity to get the most reductions. And so I think when it comes to kind of looking at these different cardiovascular risk factors, those are pretty provocative and really interesting to me.
Yeah, I think the insight I'll add on to that in terms of resistance training, what I remember learning back in undergrad exercise science is, well, when you increase in the immediate post-exercise phase, when you're lifting heavy weights, and if you're doing Valsalva or something like that, you're going to increase blood pressure, right? And so when you increase that afterload, your heart has to work much harder, right? There's this concept of the athlete's heart, and we often see right ventricular hypertrophy as a response remodeling wise, but we also see sometimes left, although most of the time that's pathologic, right? You don't want that. Is that correct? Left
So
LVH?
So we do see both. Yeah. So we see LVH, and actually we also see increased systolic like volumes
Hmm.
in resistance training athletes that typically does resolve with deconditioning. Although at this point we don't typically recommend deconditioning, so we don't necessarily consider it pathologic.
Right.
Really, the main reason we would have people decondition was just to make sure that it wasn't that it wasn't pathologic, so that it
Yeah.
wasn't hypertrophic cardiomyopathy or something like that.
but the increased contractility that would come with the, ventricular thickness, would that not explain it in terms of kind of the overall benefit, to answer Darsh's question, in terms of the mechanisms?
Oh,
Because
in
if you
terms
have
of
ventricular hypertrophy, your contractility would increase, right?
correct.
Right.
Typically. I
So
mean, it depends. So yeah, so we didn't, so in terms of the athletes hurt, we don't consider it necessarily like pathologic in that it's increasing your risk of developing heart disease, if that's what you're
gotcha.
asking.
Okay. And so from, again, now quote unquote cardiovascular exercise or the aerobic training, right? My understanding is, again, so you bring more preload, right? The heart's capacity of how much it can hold before it pumps all that blood out throughout the extremities, which will down the road allow it to have a lower heart rate. So it has to pump less frequently, right? And so you can have cardiac output can remain high. Um, is that kind of how the conversation you're having with folks when you're explaining why aerobic exercise is beneficial, or are there something else, like is there something else that you're talking about?
Oh, sorry. So going back to aerobic exercise.
Yeah,
Right.
I'm going
So
back to it. Yep.
yeah, so I mean, we see all kinds of changes in terms of the things that occur within the body in response to aerobic training. So there's all of these different sort of hemodynamic changes, and then there's also, I mean, we see increased HRV, we see obviously decreased blood pressure, we see increased insulin sensitivity. I mean, there's tons of different changes that occur within the body in response to aerobic training.
Awesome. Go ahead, Darsh.
Yeah, Dr. Hart, is there a limit that you'll put your patients on in terms of running and how much aerobic exercise? I mean, I think there's data out there that suggests like a lot of marathon runners actually can develop AFib later on just by the mechanisms that we're talking about, right? Is there anything like that that you kind of
Yeah,
caution?
so I think we are increasingly realizing there is such thing as too much of a good thing.
Mm,
Most of the benefit, so as I said, we recommend 150 minutes of moderate intensity exercise a week. We definitely see continued benefit up until around 300 minutes a week. And then from there, definitely likely a plateau. As you said, there's definitely been some studies with really high level athletes having actually higher levels of coronary artery calcium so they've done studies with high level athletes and they have higher rates of CAC, and then AFib, as you mentioned, there's been some of that as well. So I think that there is probably such thing as too much of a good thing, and I think that's another way in which some of my patients who are doing lots and lots of aerobic activity, it's a good way to sort of let's diversify your routine a little
mhm.
bit and add in the resistance training, not only because there is potentially that signal of harm at very, very high levels, but also because of all of these amazing benefits from strength training as well.
I like that. Yeah. And just to mention kind of Peter Attia's model for exercise with longevity, he talks about having a solid aerobic, anaerobic, stability, and strength program. And when you kind of have all of those four aligned is where you'll kind of be the most optimized, if I can say. Awesome. So,
Yeah, and I
yeah,
think
go ahead.
also I would just also mention that I think we're talking about sort of discrete moments of intentional activity that we're doing, but I think also
Mhm.
what gets missed a lot is sort of all the other movement that we should be doing throughout our day, because being sedentary is really associated with some of the highest levels of mortality, and there's actually some data to show that even if you sit at your desk all day long and you do your 30 or 45 minutes of exercise, that may not even discount that sedentary activity. And so I
Mhm.
think it's also important that yes, we get our 30 to 45 minutes in of whatever our activity is that we're choosing to do, but then also carving out moments of other moments in our day where we're not just sitting at the computer all day. So if you can take a walking meeting, or if you can take the stairs, or like all these other ways that we can increase our NEAT, I think that's also important and bears mentioning, because it's not as sexy as the other stuff, but it's
Mhm.
actually really important.
That's a very, very, very important point that you brought up that I don't know how Altosh and I missed her there, but no, thank you so much for bringing that up. Then something I've been doing at least is after a meal, trying to just even do like a 2 to 5 minute walk, right? Just to get those steps in, also kind of help the sugar regulation and everything. So very good point. All right. I want to move on now to stress. right? Something that we could all use a little bit of now, in a good way. But with COVID and with us being in the healthcare, I mean, stress is always at an all time high, I feel like, for us. What is the biggest marker, at least in the cardiovascular world, that you're seeing with stress? Is it blood pressure that usually, you're seeing? Yeah.
Yeah, so definitely stress. I think that's another area of within lifestyle medicine that is poorly studied, but we certainly do have data that indicates that chronic low grade stress is likely associated with increased risk of cardiovascular disease. Previously, the data was mostly looking at kind of acute periods of high stress like PTSD and stuff like that. The chronic low grade is probably not so good for us either. But in terms of pathways and things like that, certainly the blood pressure association is where it's best studied. And interventions like meditation and other stress reduction techniques. While we don't have a lot of data, what we do have shows that we can reduce blood pressure with specifically transcendental meditations, what's been studied best. But we do have some evidence that it can be helpful.
So maybe the more important question, what's your intervention when it comes to this? I think like when we talk to most folks who are maybe in this space, right? I mean, this is maybe the most challenging. Personally, for me, it's probably the most challenging. We're all in medicine. I mean, stress is it's ubiquitous in our daily thing. We're parents now. You talked about getting steps in, you're running after your children. That's a workout, right? I'm sure. But when your patients are coming to you and you're talking about this distress tolerance, what's your conversation like? How are you approaching that?
Yeah. So I think so. First, I have them, talk to me about. First, I have them rate their stress, and I find that a really useful point in terms of figuring out where are they. I do have an occasional patients that give me a one, and I'm like, okay, what are your secrets? Teach me. But most people, especially right now, are pretty high. Give it, an 8 or a 9, and so that helps me frame the conversation because I do hour-long intakes, but again, you only have so much time, and so I like to know where how much stress are they having, and is this something that we really should address. And so I first have them start there, and then if they are having a lot of stress, I talk to them about, or I ask them rather, where is their stress mostly coming from. Sometimes we're able to do some problem solving in terms of finding the root cause and working on trying to find ways to reduce that stress if it's one discrete thing. But more often than not, it's again this chronic low grade stress from a million different sources. And so I talk to them about stress reduction strategies. And so some people are open to meditation, other people aren't. I think that it's actually quite helpful that there's so many different apps. I think there's like an app for every personality at this point for meditation. And so most people just need to hear that they should give it a try, and that there are options, and you don't have to be good at it. And that I feel like I'm quote unquote not good at it. I don't think many people think they are. And that's not the point. The point is sitting and doing it. So yeah, I have people try the different apps depending on their personality. If they're not at all interested in meditation, we discuss other ways for stress reduction. It can be as simple as making sure they give their best friend a call every night, or taking a bath, giving themselves permission to take a bath and read a book or whatever. So oftentimes it's not this like groundbreaking, amazing stuff that no one's ever heard of, but it's having that conversation and having your doctor tell you this is important and you need to carve this out and let's figure out a way. And it doesn't have to be long. Like I meditate 10 minutes before bed. Ideally I have longer, but I don't right now, and that's okay. And so it's all about kind of having someone help you figure out a way to put that into your life and try to really make it a priority, and also just doing your best and not aiming for perfection.
I love that. I think meditation brings a lot of perspective not only in the moment, but also to the rest of those lifestyle pillars, right? When you actually get the time to sit down and reflect, you start to look at everything else in your daily routine. And I think that's where you also get to see the change. So not only from the stress perspective, but also from, okay, the diet, the exercise, how do I kind of get better, right? By 1% every day. I want to touch on another method, at least that's kind of been booming now, which is in the biohacking world, which is the sauna, which I don't even think should be a biohack because I mean, there's so many great benefits that we now know. And when I listen to other cardiologists on podcasts, I've routinely been hearing that this might be a proposed treatment in the future where we'll actually write on a script saying, go to the sauna for 20 minutes. What is your take on saunas based off like the papers you've read and if people can even tolerate it, right? I mean, I don't think it should be probably for everyone, but you probably have to be at a baseline, somewhat of a healthy level in order to get into a sauna.
Yeah, no, I definitely have. I can think of one patient who was not in a place in his health where I recommended the sauna because I actually was concerned he was pretty unstable. But yeah, so I think sauna is really interesting. I think it, like a lot of things that we're starting to learn, is really interesting in terms of the impact that it potentially could have, simply because of how it can stress your body in a good way and get our bodies used to that. So I think it's really interesting. I think we're definitely not at that place where most of us are quite
Mm.
prescribing it yet. But I think the data is certainly interesting and emergent.
Awesome. Well, Dr. Harkin, as we come to a close here, I want to, of course, thank you for two amazing discussions. But I'd be remiss if I didn't ask you about the future of preventive cardiology. More specifically, I think that the first first part of the discussion that we had, we spent a lot of time talking about areas where we're trying to understand why the current standard of, standard of care, the way we practice it, why are we looking at specific markers like LDL particle number, ApoB, even though the European guidelines suggest that. And, if somebody listens to this and they're convinced that this might be key or instrumental in their role, how can patients have a conversation with their provider for the need of these advanced testing, which may, you know, alter their care, or they may be more informed so they can make other decisions, so they can, affect different pillars of lifestyle medicine, or whether it's pharmacological treatment, whatever that might be. This is a question I wanted to ask you last time, but I didn't get a chance to, so I'm going to ask now, is how can they have a conversation, whether it's cardiologist, primary care provider, whoever it might be?
Yeah, I think that's a really good question because by and large, most people will not necessarily have a preventive cardiologist as a member of their care team. Although hopefully that will change. I do think that, whether it's based on risk factors or just you hit a certain age, I really would hope that everyone would be able to access at least once a preventive cardiologist to really kind of get a lot of their personalized questions answered. But that said, I think that like the American Society of Preventive Cardiology emphasizes that it's not just cardiologists that can be practicing preventive cardiology, right? It's endocrinologists, it's internists, it's sports medicine docs. It's really anyone who has an eye towards, preventing cardiovascular disease, which hopefully is all of us physicians and other members of the healthcare team, given that it is the number one killer globally. And so I think that certainly one, hopefully all of us will do a better job of having these types of conversations so that more healthcare professionals are exposed to these different topics. And while it can be difficult to keep up with, every emerging piece of literature, none of us can, hopefully they're, at least exposed to some of kind of these topics that are increasingly becoming important. But in terms of kind of a patient specifically being able to access some of these things, I think it's discussing with them. I think it's really important that, say you're seeing your primary care physician for your annual physical and, hey doc, what do you think is my cardiovascular risk? Like, have you plugged me into the ACC/AHA 10-year risk calculator, or whatever it is. Maybe not that specific exact language, or they could. Why not? Have you?
After listening to this, they will.
Because I think that, your average PCP has like 8 million things that they need to check and do. And so be just kind of bringing that to their forefront of their mind and reminding them that this is something that's super important to them. Is a great way to kind of start the conversation. And maybe the doc will be like, oh yeah, your risk is pretty low for XYZ reason. And so maybe you don't need additional testing at that point, but potentially they will be like, oh, I haven't checked it, let's check and see what's your risk. Or, the next question could be, hey, do you think I would benefit from a coronary artery calcium score, or, whatever it is. And again, not everyone needs these types of tests, but at least it's, if you're interested or you think you might benefit, having those conversations. And if you feel like your provider sort of goals are not in align with yours, then finding someone who has, who is more in line with what you're looking for. Not everyone's going to be the right fit for everyone. It's not a personal thing, and that's totally fine. But I think that, starting to have those conversations in a really, just non-judgmental, non-accusatory way, but hey, I was thinking about this, or hey, I read this, what do you think? And starting that conversation.
So on the flip side, hey, I just checked ASPC out. I actually didn't even know it was a thing. I'm definitely going to look into becoming a member. That's awesome.
You
Maybe I'll see
should.
you in Louisville, Kentucky. It looks like in July, so that's awesome. If a healthcare practitioner or somebody who has an interest, right? I mean, you mentioned last time that cardiology is very, very cool. I obviously think so as well. And I think you've made a pretty good case that it is cool in these last two discussions. If not, it is very, very important considering the burden of cardiovascular disease. And if providers want to learn more about this type of stuff, right? Some of the advanced testing, preventative cardiology, and specific, what resources could they use or to learn more about this stuff?
Yeah, absolutely. So I think that so the ACC has CardioSmart, which is a lot of patient but also provider resources. They have some podcast series at this point, lots of handouts that you can use for your patients. The American Society of Preventive Cardiology, I think, is another great organization that has a lot of great content that is being put out in terms of guidelines and things like that. Definitely familiarizing yourself with the ACC/AHA guidelines. There's the primary prevention guidelines, and then digging deeper, right? So read, if you're interested, reading the guidelines, and then looking at the resources, looking at their sources, going into the primary literature if you have time. It's really, illuminating, and that's where you can start to kind of better understand where these guidelines are coming from.
You might have forgotten the most important one. I think wholeheartcardiology.com. Is that right?
Absolutely. So my website's Whole Heart Cardiology. And yeah, I have a blog and a newsletter and all that kind of stuff. So it's mostly geared towards patients, but I actually have a handful of my primary care docs that routinely refer to me that have subscribed and say they actually really enjoy it.
Awesome. Well, Dr. Harkin, it's also International Women's Day, so happy International Women's Day to you. In cardiology, women are definitely represented, and you're just proof of that as to why we need more and the value that you create. So thank you very much for coming on here. Final question for you is, how do we add the health back in healthcare?
Great question. I think by all of us advocating together for what we need, I think that both physicians and patients are frustrated with where we're at. And so I think that the more of us on both sides of the equation that speak out, the better. Because I think that, patients just come to me time and time again, why has no one talked to me about this before? I can't believe I'm hearing this for the first time. And I truly, it is just, it's frustrating that no one's getting the care that they want. We spend so much money as a nation on our healthcare, and yet we are sicker than ever. And so we all deserve better.
Love it. Yep. Couldn't have said it better. So thank you so much again.
Thanks so much for having me.
All right. Wow. What an episode. I hope that was beneficial for you all. And again, if you haven't listened to part 1, go ahead and go back to episode 55. with Dr. Harkin, where she will explain essentially the basis of cardiovascular disease. I mean, we go into cholesterol, statins, risk factors, and we start to talk about how our understanding of cardiovascular disease is changing and how we might have had some things wrong in the last decade or so, and how we can at least empower the consumer, the patients, to get the testing that they need to understand their own cardiovascular health. And if you stick with us here in the upcoming weeks, we are going to have another cardiologist coming on to talk about something a little bit more futuristic, and that is going to be wearable technology. So excited to produce that episode as well. And as always, if you are enjoying this episode and this series of Medicine Redefined, go ahead and share, subscribe, rate, and review. And just some news, we are officially on TikTok and YouTube now. So if you enjoy seeing short clips, you can go ahead on YouTube and TikTok. We have video form now of some of the clips from our podcast for your viewing. And as always, the medical disclaimer, everything in this podcast is for educational purposes only. It does not constitute the practice of medicine, and we are not providing medical advice. No physician-patient relationship is formed, and anything discussed in this podcast does not represent the views of our employers. We recommend that you seek the guidance of your personal physician regarding any specific health-related issues. And with that, we'll see you next week.